So I think now is the time for the panel discussion. Please, if you have any question that to be direct to the speaker, you can ask them in the question area. Dr. Wafa, please, if you don't mind, can you be with us on the stage? Dr. Wafa, please, I have the first question, if you don't mind. So, apart of your experience, how do you see the transition program in Saudi Arabia?
Can you repeat the question, please?
He's asking about how do I see the transition program evolving in Saudi Arabia. I think
regarding postgraduate training, you mean?
Dr. Khalid, this is a question for Dr. Wafa Aswari.
Okay. I think it will be challenging since the age, cut-off age in our practice is usually by 14. So it will be really challenging, and it takes really a good effort from both adult and pediatric. In my experience, limited experience actually in our hospital, we managed to do it even though the age is still, the cut-off age is 14. But this has to take a very good collaborator, adult traumatologist, and we do it actually with in a progressive, gradual way. So each center has to come up with what is suitable for them in order to implement the transition. It is usually led by the pediatric rheumatologist, not the other way around, by adult. I do believe that there should be a future subspecialty actually in adolescent rheumatology that needs to be promoted either in pediatric rheumatology or adult rheumatology practice. In order to support this, we need a future education in both adult and pediatric. And and I heard recently that there is a discussion about extending the pediatric age in Saudi Arabia till the age of 18. If this is going to happen in the near future, that will support very much the process of transition.
I think we have a question from the Professor Mayouf.
Assalamu alaikum. Dr. Wafa, thank you very much for this important topic for patient care continuation. In my opinion, Doctora, there is one important factor of transfer failure, and I believe the nature of the disease itself.
Yeah.
If it comes to lupus, no one of our colleagues from adult rheumatology will refuse to see or accept the patient.
Yeah.
But when it comes to the new disease, we are seeing right these days like immune dysregulation disease, autoinflammatory disease, syndromic inflammatory diseases. Probably we feel some reluctant from our colleague from adult rheumatology to accept and to follow those patients. So I'd like to get your comment on that, and probably we need to hear also from our colleague from adult rheumatology.
Yeah.
Thank you.
I totally agree with you, Prof. Sulaiman. This is a very challenging group of patients. And in our center, we agreed with our colleagues in adult rheumatology to have a leading care by pediatric rheumatologists because they don't have the experience in managing, for example, CAPS, TRAPS, or hyper-IgD syndromes. They lack the knowledge and the experience in those patients. So we do share the care with them. Outpatient with us. If there is a need for inpatient and they got admitted, we share the care with them. But this is really a growing up of a group of patients with immune dysregulation, autoinflammatory diseases. That is the nature of the disease itself. As our colleagues in adult rheumatology completely lack the experience, and we do appreciate this, and they do appreciate this. So I hope to hear from adult rheumatology their opinion.
I think there's a question for Dr. Khalid. Patient has been diagnosed with the isolated non-infectious anterior uveitis and has been on Cellcept 3 grams per day, but his condition was not improved. So what is the best next step in his management?
Cause of the uveitis. If it's an idiopathic cause of uveitis with non-granulomatous uveitis, we go to biologics after the mycophenolate mofetil. 3 grams is a good dose, and sometimes we go to biologics in order to control such conditions. But of course, you have to know the cause of the anterior uveitis. But if it's idiopathic, bilateral, and not responding to Cellcept or mycophenolate mofetil, then one has to consider biologics in these patients.
Okay, thank you so much. So I think with this question, we'll close the panel discussion, and we reached to the finish the first session. I would like to thank Professor Sami as a chairperson. Please, Professor Sami, if you have any word before to finish.
I would like to thank the speakers. Again, I'm very happy to see that everybody is careful. Tabaud, Kamamat. I hope this continue for the end of the conference. Thank you very much for Dr. Fahid again for his introduction and for his nice word. Thank you.
Thank you so much.
So thank you, dear respected chairpersons and the speakers for participating in the first session. And now we move on to the second session. The second session is an exciting session. It's about the oral abstracts that were submitted to the research committee for the Saudi Society of Rheumatology conference for this year. And it gives me an immense pleasure to introduce the respected chairpersons for the second session. The first chairperson is Dr. Ramiz Aswalim. Dr. Ramiz Aswalim is a well-known senior consultant rheumatologist at Prince Sultan Medical City at Riyadh. He is also the past president of the Saudi Society of Rheumatology. He held numerous administrative and scientific posts and published several articles in the field of rheumatology. Welcome, Dr. Ramiz. The second chairperson is coming all the way from the East Coast, Dr. Manal Hassan. Dr. Manal Hassan is a consultant rheumatologist and internist at King Fahd University Hospital at Al Khobar City, and she is also an assistant professor of internal medicine and rheumatology at Al-Imam Abdurrahman bin Faisal University in Dammam. So without further ado, welcome Dr. Manal Hassan and welcome Dr. Ramiz.